Daily injections are ideal because this gives you ultra stable testosterone levels. If you can really frequently administer something with a very long half-life, you can keep your levels super, super stable. And I think that this is the most beneficial way to do TRT. However, how should TRT be administered? So TRT should be administered as frequently as possible to mimic natural production as closely as possible to prevent supraphysiological peaks or low troughs with deficient androgen levels. Previously, there were some arguments to suggest that higher SHBG benefited more from less frequent injections. This is bro science and is not true. The higher someone's SHBG is, the higher the total dose needs to be to optimize free testosterone, but it is not something that allows for a more advantageous treatment protocol for injecting less often. It is always more beneficial to inject more often or to apply testosterone more often for stability. Stability is one of the most important factors for optimizing a man's hormone system. Now, when we're looking at injecting, we have to find the sweet spot between what is something that is optimal and what is something that someone will do consistently for the rest of their life. Injections are not overly painful, but they are not completely comfortable. They are not as comfortable as swallowing a capsule. So we want to find a way that we can inject as often as possible, but not excessively to allow us to have stable serum levels so that we can do this for a lifetime, and ideally with the least amount of pain and discomfort. We'll also be discussing topical cream. So testosterone cypionate and enanthate injections are our typical injections for testosterone. There are other forms of testosterone on the market, such as Sustanon, Libido, also known as Reandron, which is injectable testosterone undecanoate. And testosterone propionate is not typically used for TRT, but I guess it could be, and I'm sure in some countries it is, but it is much, much, much rarer. This lecture will be focusing on cypionate and enanthate because I would say about 90% of people watching this will be using these forms or should be using these forms. Sustanon is very popular in the UK, and I would say that the same approach applies to Sustanon, but I would recommend that people inject a little bit more often with Sustanon due to the concentration of propionate and phenylpropionate. I don't recommend Reandron or Libido. They simply do not work. So when we're looking at cypionate and enanthate, we say that we want you to inject it at a minimum of twice a week. There is also the option of using a highly bioavailable topical compounded cream, which can be applied to a shaved scrotum, ideally twice a day. When we look at injections, and I think there's a really good point to be made here, injections are not comfortable. Other than masochists, I don't think anyone really looks forward to their injections. Maybe at first there's a bit of a novelty, but once that wears off, I don't think anyone really wants to inject anything unless you have to. So given that injections are still the gold standard for testosterone replacement therapy, it means that the other options simply are not as good. Otherwise, we would pick them over injections. Now, topical transscrotal cream, which I'm going to discuss next, I would argue is coming up to the point of being equally popular and equally effective to injections. But this is something that is slowly rolling out across the world as more people become aware of it. And I would argue that there are definitely situations where it is advantageous over injections, which I will be discussing more in the TRT Academy component of the masterclass. So cypionate and enanthate are extremely similar. I liken them to Coke and Pepsi. They're basically the same thing, but they're a little bit different. Cypionate has one extra molecule as part of its ester structure, leading to a slightly longer half-life. Now, given the half-life, depending on the research, is estimated to be anywhere from about 5 to 10 days. My understanding is that it's about a week. Some studies show it as low as even under 4 days. Some studies show it as long as 10 to 14 days. I think that the depth of the injection is a factor. Arguably, the carrier oil is also a factor as well. But when you average it out, when you look at the pharmacodynamics in the graphs, it's about a week, give or take. Now, given that cypionate has a fractionally longer half-life, I would argue that given that fact, it is slightly superior to enanthate if we're going to compare the two. It is splitting hairs. They are both completely interchangeable. There is nothing wrong with enanthate, and generally you'll have one or the other available. What we want to do is inject it more often than the half-life peaks and troughs. So what a half-life means is that if the half-life of a drug, let's say, is 10 days, it means it takes 10 days to eliminate 50% of the medication, bringing it down to a 50% concentration. Then it takes another 10 days to eliminate 50% of that, bringing it down to 25, another 10 days to 12.5, and so on and so forth. I think that a lot of the time, half-life is conflated with mean residence time, which leads to some confusion around these because this takes into account where the medication peaks and how the medication is distributed between the peak and the trough. But what we find to achieve stable levels and minimal fluctuations is that twice a week is the minimum that can be done. I would argue that it is much more advantageous to inject 3 times a week than twice a week, especially if your metabolic health is not optimal because you will be more sensitive to the peaks and troughs. What I like to say is you can get away with twice a week, and twice a week is okay, but 3 times a week I think is more advantageous. Guys can do every other day if you want to. It does mean the day of the week will change every fortnight, but it's not the end of the world. I just find it easier to say Monday, Wednesday, Friday. You've got multiple half-lives banked up over the weekend once you've been on treatment chronically, so it's not like you're going to dip by Sunday night. And this gives you a consistent, easy schedule to follow, easy to comply over time. You don't have to worry about it on the weekend. I think it works very well, and it delivers a nice sweet spot. Injectable formulations typically come in 200 or 250 milligram per mil. I think anything less than that is just not worth using, but I guess if it's all you can get, with weaker concentrations being less ideal. In the US, the vast majority of TRT patients are using 200 milligram per mil. There's nothing wrong with this. But 250 milligram per mil is going to be better simply because you get more in a vial and you need to inject less of it. 200 milligram is not problematic. It is not bad, but if there's a choice between both, for obvious reasons, 250 milligram per mil is going to be best. To maintain consistent levels across a 7-day period and to avoid peaks and troughs, which are one of the main factors which induce side effects or lack of symptom resolution, we're looking at a minimum of twice a week. There's many men who benefit more from 3 times a week compared to twice a week. And as I said before, a big subset of these men are men with poor metabolic health. But there also seem to be guys that just metabolize the ester faster than others. I hypothesize that this is due to whichever liver enzymes are responsible for cleaving the ester in these men. It actually hasn't been identified which liver enzymes are metabolizing which ester, but I hypothesize that these men have upregulated enzymatic function, which is the primary factor for cleaving the ester. That's my theory, at least. So, as I said, every other day injections provide a similar outcome to 3 times a week, given the long half-life, but it is more of a tricky schedule to maintain. But if you prefer every other day, then by all means, there is nothing wrong with that. So, as I said previously, and I think that this is the best way to put it, is that the injection protocol should be as often as the client or patient will sustainably do over time. You want to inject as often as you can be bothered for as long as you can. I don't think anyone would prefer to inject than not have to take anything, but given the benefits of TRT, I think 3 little injections into the deltoid or the ventroglute with a tiny little insulin syringe 3 times a week is absolutely worthwhile for the benefits that you receive from TRT, especially with the ultra-stable serum concentrations. One thing that I will flag before we continue is that SHBG in groups, and I've even seen on some YouTube videos, is often touted as the primary variable for determining how often someone needs to inject. I think that this is fundamentally incorrect, and I think that this is a concept that has been parroted so many times that people actually haven't sat down to think to question this. I think that other than determining total testosterone dose and also being potentially a red flag for things like chronic dieting, excessive ketosis, as well as things like insulin resistance and hypothyroidism when it's high or low respectively, SHBG does not impact the half-life of the ester, which is the primary determining factor for injection frequency. It is only really responsible for determining the total dose needed to optimize free testosterone. It does not impact the rate in which the ester is cleaved. It only impacts the half-life of the testosterone once that ester has been cleaved, which I think relative to the former is inconsequential in injection frequency. You should inject as often as you can, regardless of your SHBG level. Very happy to debate anyone on the subject if they would like to come on the channel and do a discussion. I'm also going to flag here, daily injections are ideal because this gives you ultra-stable testosterone levels. It's kind of like if you were drinking coffee, not that you'd want to do this, but instead of having, a shot of espresso in the morning and a shot of espresso at noon, you'd just be sipping on coffee from dawn to dusk, assuming your goal was to remain caffeinated over the course of the period, which would not be good for sleep. But you get what I'm trying to say. If you can really frequently administer something with a very long half-life, you can keep your levels super, super stable. And I think that this is the most beneficial way to do TRT. However, when performing intramuscular injections, these are not sustainable long-term. I see some guys maybe do shallow IM injections with daily shots for a year, maybe 18 months, maybe 2 years, but I don't know anyone who's been doing it for more than 5. So if an individual tolerates a protocol well with a subcutaneous injection, this can also be an effective protocol. The literature shows that subcutaneous injections are very effective. In practice, however, a lot of men do receive welts and lumps and bumps and significantly lowered serum levels because they don't absorb it well through the subcutaneous tissue. This is simply the reality of what happens in practice. There can be as many studies showing that the sky is green and why the sky is green, but if you go outside and it's blue, it's most important that the sky is in fact blue. This is the reality of it. So my approach with this is that if you tolerate and react well to subcutaneous injections, and I also think that the carrier oil and how the testosterone is compounded is a big factor in this, and I imagine this is why practitioners who swear by subcutaneous injections likely also have a product that they consistently use for this. If this works for you, fantastic. Subcutaneous injections arguably reduce peaks and troughs even more, so you get super stable levels. But most importantly, you can now do an injection daily, sustainably, long-term for the rest of your life. You inject less often than most diabetics would using the same equipment. So this is absolutely sustainable and something that if it works for you, fantastic. However, I do find that about 50% of men do not react well to subcutaneous injections. If 100% of men reacted well to it, none of us would be injecting into the muscle purely from a comfort standpoint. As you're watching this on YouTube, you will have worked out that this is a free masterclass. I am very passionate about making this information as accessible and as understandable as possible. What was considered best practice then may not be considered, and from 10 years ago definitely is not considered best practice now. A lot of the content that I make is talking